Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. We are currently in our neurology sessions, and this is Brainstem and Motor Control Part 2. So here we have damage to which of the following spinal cord areas is most likely responsible for this patient's symptoms. So a 20-year-old a woman comes to the physician because of multiple burns on her hands. She says that she gets burned quite often when she cooks, particularly while operating the oven. She also has burned herself when picking up her morning cup of coffee and when testing the water temperature in the shower. The patient is concerned because he cannot feel when objects are really hot and often does not notice that she has burns until she looks at her hands. She has no significant past medical history, no recent illnesses, and no sick contacts. Her surgical history is significant only for removal of impacted wisdom teeth 1 year ago. The patient has never smoked, drinks alcohol occasionally, and does not use illicit drugs. Her family history is significant for multiple sclerosis in her mother. Examination show diminished pinprick and temperature sensation across the upper back, shoulders, and arms bilaterally. Light touch position and vibration sense are preserved. Examination of the lower extremities is unremarkable, and damage to which of the following spinal cord areas is most likely responsible for this patient's symptoms. So A, B, C, D, E, F. So here we can see that the patient is typically young patient, okay, 20-year-old young patient, and the patient is generally having a decrease in the pain sensation. That's why she is not getting uh, pain whenever she touches a very really hot object, because whenever we touch a really hot object, we have a reflex of withdrawing our hand. She does not withdraw her hand and only finds out that she has been burned only when she looks at her hand. And on examination, it is said that the patient is having diminished pinprick and temperature sensation across the upper back, shoulders, and arms bilaterally. Now, that is a cape-like distribution of the pain and temperature sensation uh, diminution. Also, we can see that the patient is having position and vibration sensations are preserved. Now, in this image, where do you think is the defect that the patient is having bilateral pain and temperature defect? So this patient most likely has syringomyelia, which is a classically presents with a disproportionate loss of pain and temperature sensation involving the arms and hands. In syringomyelia, a cerebrospinal fluid-filled cavity called as syrinx usually forms in the cervical regions of the spinal cord. Now, these cavities can enlarge over time and destroy adjacent portions of the spinal cord. The areas most commonly damaged are ventral white commissures and ventral horns. The ventral white commissures is located just anterior to the gray commissure, and it is the area of decussation of the fibers of the lateral spinal thalamic tract, which transmits the pain and temperature sensation from peripheral receptors to the somatosensory cortex. Destruction of the ventral white commissure leads to loss of pain and temperature sensation bilaterally over the affected dermatomes, starting one to two levels below the lesion, as the axons briefly ascend in the zone of leisure before decussating. So touch, vibration, and position sense are preserved as dorsal columns remain intact. So now we can see in this picture. So wherever here is the syrinx and the parent temperature comes stand 2 to 3 spinal cord up, and then they decussate like this. Okay. So whenever there is defect in the midway, then it will affect the parent temperature at both sides. So that's why there will be the bilateral loss of parent temperature sensation. Also, now this area is the DCML. So DCML carries our light touch position and vibration strengths. Now these are not affected in case of syringomyelia. That's why the patient will be having normal light position and vibration senses. So choice B, the ventral horns contain lower motor neurons that receive impulses from the lateral corticospinal tract. Damage to this horn can occur in syringomyelia, but will cause flaccid paralysis and atrophy of the intrinsic hand muscles. The ventral spinal thalamic tract is located in this area and transmits crude touch and pressure sensation, and it should not be confused with the lateral spinal thalamic tract, which carries the pain and temperature sensation. After negotiating in the ventral white commissure, axons of the lateral spinal thalamic tract ascend into the brain in the lateral funicles. Now, damage to this area would cause contralateral loss of pain and temperature, senses and distally, beginning 1 to 2 segments below the lesion. However, bilateral sensory loss would not occur with damage in this area. The dorsal horn contains first-order axons and second-order neurons that transmit sensory input from peripheral receptors. Damage to the dorsal horn would likely result in the unilateral loss of all sensation over the affected dermatomes. The dorsal column contains both the gracile and cuneate fasciculi, and they are formed by axons of first-order neurons of the dorsal column pathway. This tract is the primary mediator of proprioception, vibration, and tactile sensation. Now, this is the syringomyelia, okay? So it is generally in the cervical region and it is a fluid-filled cavity. So there is now, this is the touch, proprioception, and vibratory sensation. This travel to the dorsal column medial lemniscus pathway, and syringomyelia do not involve this. Also, here you can see the pain-carrying fibers, they decussate here like this and goes to the other opposite side. So due to the syrinx, there is the midway pathology, which causes the bilateral interruption of pain and temperature fibers, and then the patient will have bilateral pain and temperature loss. Now, this is the typical spinal cord and associated tracts. A picture, a slide from your own first aid. So the legs, lumbosacral, lateral, lateral corticospinal, and spinothalamic tracts, and the dorsal columns are organized as you are with hands at sides. So arms outside, leg inside. So let's first discuss about the blue pathway. So everything here in blue is the ascending pathway. So ascending, so sacral, lumbar, thoracic, and cervical. Now, how you can remember the sequence of these fibers? Now, imagine that we have um, the lowest vertebra, okay, the lowest level of vertebra. Now, from there, first of all, the sacral fibers come in, and the sacral fibers will align like this. And then when you reach to the lumbar region, again, the lumbar fibers come in, and it arranges like this. So the fibers do not cross each other. It is arranged like it is coming in the spinal cord, okay. Like it is incoming in the spinal cord. First, the sacral fibers are incoming. You move from down to up. First, the sacral fibers are incoming, then the lumbar fibers, then the thoracic, and last the cervical fibers are incoming, and then they move upward. So the fibers don't have to cross, okay? So that's why it is the DCML pathway. It is the DCML part, and it helps in the pressure, vibration, fine touch, and proprioception sensation carrying capacity and function. So fasciculus gracilis, so L for L, L for lower limb, and L for lower body and legs. So fasciculus gracilis contains sacral and lumbar area, whereas thoracic and cervical is through the thoracic cutaneous, okay, upper body and arms. This is the gray matter. This is the intermediate horn, which contains the sympathetic chain. And this is again the ascending pathway, the lateral spinothalamic tract, which carries the pain and temperature. Okay, again, sacral, cervical, and sacral is the outside, and cervical is the inside. Now you can see why the sacral is the outermost, because the sacral, the pain pathways, the pain fibers, they cross in the spinal cord. So when the pain pathways come from this side, and for example, the pain from the sacral pathways or the sacral fibers, when they're incoming from the opposite side, then they just travel like this and they meet here, okay? And from here they go up. Again, the fibers from the lumbar will again come here, and they will lie just beside the sacral pathway, the sacral area. Again, it's the same with the thoracic and same with the cervical. So that's why here the fibers have decussate, and again, due to the decussation, the sacral has come in the most furthermost part of the spinal cord, and cervical in the most nearest part of the spinal cord. Now, let's talk about the descending or the lateral corticospinal tract or the anterior corticospinal tract. So descending means the fibers are coming from the brain towards the spinal cord. So, for example, here we have the sacral again, and the lumbar, thoracic, and cervical part. And this is the uh, anterior corticospinal tract here, which is again one of the motor tracts, and these contain the voluntary motor fibers is from the both the descending pathways, the lateral corticospinal tract and the anterior corticospinal tract. Now let's discuss about the spinothalamic tract. So its main function is to carry the pain and temperature pathway, right? So spinothalamic, from the spine towards the thalamus. So its main function is to carry the pain and temperature. So the first order neuron is the sensory nerve here, in a sensory nerve ending of pseudounipolar neuron, okay, and then it enters the spinal cord. And then the first synapse is in the posterior horn of the spinal cord here. Now, this is the first synapse. And again, this green colored is the second order neuron. Now, this second order neuron then decussits in the spinal cord as the anterior white commissure and ascends contralaterally. And then it ascends all the way up to the ventroposterolateral nucleus of the thalamus. And then it again synapse there. From the thalamus, third order neuron comes and then it takes the sensation through the third order neuron towards the primary somatosensory cortex. This is the spinal thalamic tract. Again, talking about the dorsal column medial lemniscus pathway. So it carries the pressure, vibration, fine touch, and proprioception. Okay, the sensory nerve ending of the pseudounipolar dorsal root ganglion is the first order neuron, and it enters the spinal cord, and then it travels 2 to 3 cord up, and again it may synapse in the dorsal column. Okay, it synapse in the uh, dorsal columns, and again in the posterior horn, and again then the second order neuron starts, and again it decussits in the opposite side, and again it synapse again in the VPL, the ventroposterolateral nucleus of the thalamus, and from there again the fibers are taken up to the primary somatosensory cortex. Now this is the corticospinal tract. Okay, now see how the information is carried out from brain towards the muscle fibers. So it helps in the voluntary movement. So upper motor neuron is the primary motor neuron, cortex, descends ipsilaterally through the posterior limb of the internal capsule and cerebral peduncle, and decussits at the caudal medulla. Okay, now this is the medulla, and here it decussits like this. Here it decussits and it reaches the opposite side. That's why your right side of the body is controlled by your left side of the brain. Okay. Now, if you are right-sided person, your left side of the brain is more active. So, descends contralaterally, and again, it then leaves the spinal cord through the anterior horn. Okay, and then it again synapse at the neuromuscular junction. Now let's talk about some of the pathology of these pathways. So spinal muscular atrophy is when there is congenital degeneration of the anterior horns, and it is due to the autosomal recessive SMN1 gene mutation, and it causes the defective SNR RNP assembly and leads to the lower motor neuron apoptosis. So spinal muscular atrophy type 1 is also called as the Werning-Hoffmann disease, and the buzzword is the floppy baby with marked hypotonia. The amyotrophic lateral sclerosis is combined upper neuron motor neuron lesion plus lower motor neuron lesion, and also called as the Lou Gehrig disease. So the buzzword here is the patient will be having flaccid limb weakness. So both upper motor neuron and lower motor neuron signs. If it is present, then we have to think of amyotrophic lateral sclerosis. And again, the one of the important concept asked is how is the death from this in this patient? Then we have to answer respiratory failure. And talking about the tapes dorsalis, so it is the degeneration or demyelination of the dorsal columns and root of the uh, uh, and roots by the treponema pallidum in case of torticollis. So it causes the progressive sensory ataxia and positive rhomboxine and absent deep tendon reflexes. It is also associated with the shooting pain and arched Robertson pupil and Charcot joints. So it typically affects the dorsal column medial lemniscus pathway. Now let's do one more question before we finish. So this patient is at greater risk of dying from which of the following conditions? A 15-year-old girl comes to the office with gait instability. Since age 12, the patient has had mild weakness and clumsiness in her lower limbs that have progressed. She has to hold on to the railing when walking downstairs due to the several recent falls. Physical examination reveals kyphoscoliosis, pes cavus, and bilateral lower extremity ataxia. Joint position and vibration senses are also impaired, and further evaluation reveals that she is suffering from an inherited disease. This patient is at greater risk of dying from which of the following conditions: aortic dissection, brain tumor, cardiomyopathy, intracranial bleeding, liver failure, renal disease. So, talking about the Friedreich ataxia, the patient is having kyphoscoliosis, uh, hypertrophic cardiomyopathy, and high arch or pes cavus. Okay, now these whenever the question system gives you these features, then you have to think of Friedreich ataxia. The main problem in Friedreich ataxia in sort of nervous system is the involvement of the dorsal columns, okay, which causes the loss of proprioception and vibration sense. So this patient likely has Friedreich ataxia, an autosomal recessive condition that typically presents during the childhood with progressive gait ataxia due to the degeneration of the spinocerebral tracts and impaired joint and vibration sense. Lateral corticospinal tract involvement may result in spastic muscle weakness and a positive Babinski sign. Other characteristic features of Friedreich ataxia include hypertrophic cardiomyopathy, kyphoscoliosis, and diabetes mellitus. Complications from the cardiomyopathy are the most common cause of death. Keep studying hard. Thank you for watching.